After you finalize a plan with the provider to change his medication and arrange a referral, you call to discuss the plan with Mr. Adams and make sure he understands how the plan will be implemented. You counsel him on reducing his fall risk. You encourage him to continue going to his physical therapy appointments to improve his gait, strength, and balance. You also review his medications with him to ensure he understands why he's taking them and what side effects to watch for.
Medication list. Calcium carbonate, vitamin D, 600 milligrams, 400 IU, PO, twice daily. Sertraline, 25 milligrams, PO, daily. Metformin, 1000 milligrams, PO, twice daily. Furosemide, 40 milligrams, PO, twice daily. Spironolactone, 25 milligrams, PO, daily. Metoprolol succinate ER, 100 milligrams, PO, daily. Linispril, 10 milligrams, PO, daily. Atorvastatin, 10 milligrams, PO, daily. Aspirin, 81 milligrams, PO, daily. Calcium carbonate, 500 milligrams, PO, PRN reflux, max 2 doses per day.
Finally, you encourage him to come back or call if he or his family has any questions or concerns. Since Mr. Adams was discharged 4 months ago, 3 pharmacists have played an important part in reducing his fall risk: the transitions of care pharmacist, the primary care pharmacist, and the community pharmacist have helped him decrease his medications from 17 to 10. The patient has a better understanding of his health conditions and what can be done to reduce his risk for falls.
Module 4. Intervene. Continued.
Compensation for your efforts will vary depending on state laws and practice sites,
Current reimbursement mechanisms.
but may be possible through collaborative practice agreements, medication therapy management billing, or structured payment models.
Dr. Randy P. McDonough.
We're seeing people starting to identify that reimbursing pharmacists to provide clinical services will have an overall impact on reducing overall healthcare spend, and the patients achieve better outcomes. We did work with one of the largest payers in the state, and they wanted to find out if the actual work that we were doing was having an impact. And so we took care of about 600 of their beneficiaries, and we were able to show that we reduced the overall healthcare spend to the beneficiaries by about $300 per member per month. But also when we work with patients who are part of a Medicare Part D program and they're getting a drug benefit from Medicare, there are performance measures that we're being evaluated on, and we are getting paid an actual performance measure or bonus incentive if we reach certain metrics, and we've been able to do that with quite a few of our patients.
Dr. Corey A. Canelti.
And now we're starting to work with rural primary care providers with telehealth, and we're able to use annual wellness visits with this, where the annual wellness visit is, as it implies in the name, is a yearly visit with your provider, which can be performed by pharmacists to create a patient-centered preventative care plan. And during this annual wellness visit, we're able to do a fall prevention, screening, and assessment.
Sunny Lineber.
In my setting at the University of Colorado Hospital, I have not been compensated directly for fall prevention activities, but I've definitely been compensated indirectly. For example, at the clinic, we perform medication reconciliation for our transition of care patients, and in that we have fall prevention strategies incorporated into our medication reviews. We, as a clinic, are compensated for transition of care visits. In addition, the clinic is compensated for chronic care management visits, and those are provided directly by pharmacists over the phone, where we will look at the patient's medications and review them for multiple different things like adverse drug events, but including fall prevention.
Check with APhA for information on compensation and reimbursement for your efforts.